Hey guys, and welcome to the video. My name is Gil for Elevate Wellness Group. I have been making videos about this for about a decade now regarding my research and clinical practice of how we manage estradiol or lack of managing estradiol in men, specifically on testosterone replacement therapy. Now, over this time, I have not only preached a lot about the findings of some of the studies I'm going to share with you, and believe me, I've read over 100 studies specifically related to this topic, but I've chosen 4 to go over with today just to try to simplify the position. And over the years, not only have I noticed anecdotally significant improvement with our own patients, specifically with transfer patients coming into our offices already on aromatase inhibitors such as Arimidex and Anastrozole, Exexstam, etc., where we completely remove them from the drug and start to manage their protocols correctly. And they've shown significant symptom resolution and improvement overall in both biomarkers objectively, but also more importantly, subjectively reporting better outcomes. I wanted to also share the fact that I've been met with a lot of debate, a lot of resistance. I've been called every name in the book by the general public as well as other providers who think that we're doing this the wrong way. So people always say, where is your evidence? Obviously, thousands of patient cases anecdotally does hold some water, but, the field of science and medicine does not like anecdotes. So naturally, I have to provide some credible resources. So I want to refer your attention, and I will post these studies here for you to review in the video, and I have highlighted them to make them easier for you. First one from the Endocrine Society is titled The Intracrine Sex Steroid Biosynthesis Pathways. And it states, in the light of new findings that demonstrate pathways of biosynthesis of estradiol, specifically E2, and dihydrotestosterone, DHT, the 2 metabolites of testosterone, from adrenal DHEA in peripheral intracrine tissues, this is the key word, we'll refer back to this often, so remember that word, peripheral intracrine tissues, which do not involve testosterone as intermediate as classically found in the testes and ovary. Steroidogenic enzymes, different from those of the ovary and testes, act in a tissue-specific manner to catalyze the transformation of DHEA into active sex steroids. These new pathways are especially important in postmenopausal women, where all estrogens and practically all androgens are made at their site of action in peripheral tissues from DHEA, the precursor of adrenal origin. In men, on the other hand, from 40 to 50% of androgens are made in peripheral tissues from adrenal DHEA, thus indicating the major importance of the intracrine pathway in both men and women. And I will point you that this is 40 to 50% of all intracrine activity comes from DHEA. The remaining comes from circulating androgens. However, when we discuss aromatization, some of these other studies will soon show you that all of that essentially in men occurs as a paracrine and intracrine synthesis. Here's another one. This is the role of estrogens in control of energy balance and glucose homeostasis. This study is from the Department of Medicine, Division of Endocrinology of Metabolism and Molecular Medicine. This is a study out of Northwestern University School of Medicine in Chicago. And it states estrogen action. By the way, this one is sponsored by the Endocrine Society of America. Estrogen actions in hypothalamic nuclei differentially control food intake, energy expenditure, and white adipose tissue distribution. So this one discusses more of a metabolic function and the role of estrogens and its importance. Estrogen actions in skeletal muscle, liver, adipose tissue, and immune cells are involved in insulin sensitivity as well as prevention of lipid accumulation and inflammation. So think of it as an anti-inflammatory and something to help inhibit, arrest, or reverse insulin resistance, aka type 2 diabetes, or pre-diabetic conditions, which again are very prevalent to a lot of the transfer patients that we come across coming in already on aromatase inhibitors, thus preventing the intracrine action of estradiol. It further goes on to state estrogen actions in pancreatic isolate beta cells also regulate insulin secretion. The beta cells, for those who don't know, in the pancreas are responsible for insulin. Nutrient homeostasis and survival. Estrogen deficiency promotes metabolic dysfunction, predisposing to obesity, the metabolic syndrome, and type 2 diabetes. Okay, so here's another one. This is an intracrinology, role of the family of 17 beta hydroxysteroid dehydrogenases. This refers to enzymes. In human physiology and disease, this is a review from Laval University out in Quebec, Canada. And this is the Oncology and Molecular Endocrinology Research Center at the Laval University Hospital. Again, I will link this for you with highlights. Part of the abstract, in women and men, an important proportion of estrogens and androgens are synthesized locally at their site of action in peripheral target tissues. Very important to note. This new field of endocrinology has been called intracrinology. This is going back to the 1980s, guys. Okay? Intracrinology, not to be confused with endocrinology. You must define an endocrine hormone versus an intracrine hormone. Endocrine hormones are synthesized within a gland within the body, secreted into the bloodstream for the purpose of systemic circulation, unlike intracrine hormones, which act on the cell and target tissue by which they are produced. This is an autocrine function. It is self-regulated, not to be intervened, certainly not to be measured in blood serum plasma levels, which are completely moot. This is another reason we do not test estradiol in men. If you understand where it is produced and how it is utilized, you'll realize that serum levels may show a deficiency from the metabolite excretion into urine. They never will show an optimal level or a level of concern so long as everything else is optimized. It further goes on to state, to date, 7 human 17 beta hydroxysteroid dehydrogenases, okay, enzymes for short, have been cloned, sequenced, and characterized. These enzymes provide each cell with the means of precisely controlling the cellular concentration of each sex steroid according to local needs. Again, not something to be intervened. This is an intracellular process which differs at peripheral tissues around the body. Furthermore, within the same study, in adult men and women are 100 to 500 times higher, okay, this referring to DHEA sulfate levels, 100 to 500 times higher than those of testosterone and 1,000 to 10,000 times higher than those of estradiol, thus providing a large reservoir of substrate for conversion, the raw ingredient, the substrate for conversion into androgens and or estrogens in peripheral intracrine tissues. I bring you back to the intracrine nature of how this mechanism works within the endocrine system. Okay, and on the back there is a chart which I will post in here as well so you could see the difference between premenopausal women, where estradiol is in fact an endocrine hormone secreted by the ovary into the bloodstream for systemic circulation. And in men, it is an intracrine hormone because the testes will secrete testosterone for systemic circulation, while DHT, dihydrotestosterone, and E2, estradiol, will in fact be converted intracellularly via this intracrine process we are discussing. Furthermore, it states in higher primates, aka humans, because they do mention other mammals here, but we are the higher primates, where active sex steroids are to a much larger degree or wholly synthesized locally in peripheral tissues. This provides autonomous control to target tissues, which are thus able to adjust the formation and metabolism of sex steroids according to local requirements. Which means that once you introduce an aromatase inhibitor, you're systemically blocking the benefits and the effects of the conversion of androgens into estrogens systemically in the entire body. You are preventing this autonomous control of target tissues that the study is referring to. Okay, again, terrible. So in short, this is just 4 studies. Like I said, I've gone through hundreds of these. The evidence is there. If you guys want to go on PubMed, if you want to go on Google Scholar, if you want to go through some of the societies and endocrine society and metabolic literature out there. There's also neurological studies I've read regarding brain estrogen levels that are also intracrine and how neurosteroids and neurotransmitters are controlled. You need to understand the importance of estrogen and how it is not to be interfered with exogenously. We do not prescribe aromatase inhibitors. We do not prescribe SERMs. Let me see here. There was another one that I wanted to go over, which was specifically to SERMs. Here, this is mechanisms in endocrinology. Estradiol is a male hormone. This is a review from the Endocrine Society. Most clinical studies infer biological actions from serum estradiol concentrations based on the classical endocrine concept that gonadal-produced sex steroids circulate to target tissues to exert their effects. These studies do not take into account cellular uptake either after dissociation from SHBG or albumin, the two abundant proteins in the blood that bind hormones. SHBG meaning sex hormone binding globulin, which you'll hear me talk a lot about, especially if you're a patient of mine, as an SHBG-bound complex, nor local production and metabolism of sex steroids in target tissues themselves, with potential for autocrine and paracrine actions. Autocrine, paracrine. Again, you will find these words used over and over in these studies when referring to metabolites of androgens such as DHT and estradiol. You can refer to Dr. Abraham Morgenthaler's literature out of Harvard Medical regarding your department, head of the urology department at Harvard, regarding his work on the saturation model of these receptors, specifically for DHT and prostate cancer. That's all been debunked many years ago over and over, and yet industry standards are still not updated. In fact, he wrote a paper in 2021 criticizing the American Urological Association of how they need to change their standards of care, and he highlighted many points of how they are very antiquated in their guidelines. So he called for a change to the guidelines for the American Urological Association following this same intracrine model of metabolites. So again, we can beat this to death. We can argue this all day long. At the end of the day, anecdotally, thousands of our patients are doing significantly better. The goal is symptom resolution and harm reduction at the same time. So I do invite debate. I do invite critical thinking, and I do invite opposition and feedback, and whether you agree, whether you disagree. I do invite comments on this video. That is the purpose of putting content out there. It is to generate discussion, not to stand the ground, but to generate discussion. The evidence is there. I invite you to review it. I invite you to ask questions, and I thank you for taking the time to watch.